Thank you, Dr. Hidayah and Dr. Amir, for the inspiring speech. So everyone remember Dr. Amir's wise words. If you don't see your needle, stop digging. Don't keep advancing, okay? So now to start with our first lecture, I would like to invite Dr. Shamala, who is our emergency physician in Hospital Kuala Lumpur with a special interest in regional anesthesia. Dr. Shamala graduated from Kirk State Medical University and did her postgraduate studies in University Kebangsaan Malaysia. So please welcome Dr. Shamala with our first lecture, regional anesthesia setup and experience sharing.
Good morning, everyone. Welcome to the virtual Ultrasound Guided Regional Anesthesia Workshop 2021. As of late, we have been receiving many inquiries on the RA services set up at our facility. So today, I would like to take you on the journey of our startup, setup, and launching of Ultrasound Guided Regional Anesthesia in our emergency department. The outline of this session will include an introduction, objectives, a little about us, indications, setup, training, and credentialing and privileging. So, RA services, particularly in the emergency department, is an evolving renaissance. However, according to Andrew Herring, relatively few emergency departments have actually fully embraced ultrasound-guided regional anesthesia in their daily practice. According to Herring, emergency physicians are keen to master and incorporate this additional skill set in their repertoire. Establishing this faculty required preparation and commitment. And a multidisciplinary collaboration has proven to be a mutually fruitful partnership for all parties involved, expressly the patients. So according to Alexander Stone, failure of this collaboration could lead to delays in the development and implementation of patient-centered, safe procedure care and limit patient access to the benefits of regional anesthesia. For us in EDHKL, the objectives of starting ultrasound-guided regional anesthesia was, first of all, to provide an alternate modality of pain relief focusing on trauma cases, to provide safe and reliable and efficient techniques, to increase pain management efficacy and reduce the usage of opioid analgesia. And last but not least, to create an appropriate management pathway for post-procedure follow-up and collaboration with primary team. This is us. The picture was taken during one of our collaboration workshops in 2020. Disclaimer, this was all during pre-COVID era. So a little background on us. We officially started in October 2019, pioneered by our consultant emergency physician critical care, Dr. Hidayah Shafi'i. A core group was formed encompassing emergency physicians and medical officers with basic ultrasound proficiency. There were a total of 3 emergency physicians and 9 medical officers. Our mission was simple: to provide an alternate modality of pain management and minimize the use of opioids. All of this done with the collaboration of the anesthesiology department, particularly the regionalist of Hospital Kuala Lumpur. So first of all, we started off with in-house training. So we had lectures on core principles of UGRA or ultrasound guided regional anesthesia, anatomy and sonoanatomy, and clinical applications. We had hands-on practical sessions for basic applications of UGRA. We had regular discussions and development of lecture materials on core topics. All of this again was guided by our critical care consultant in the emergency department. Our one and only major support was from our anesthesiology colleagues, especially the regionalists. We scheduled attachment in rotation for our core team at the OT, where we had a chance to perform ultrasound-guided regional anesthesia under supervision. The OT attachments lasted for about 2 weeks each. This hands-on training was crucial in developing our skills and, of course, confidence. Disclaimer, with the pandemic on the rise at that time, we did encounter some difficulties in completing the OT training for all of our team members. With this new skill in tow, we started actively performing ultrasound guided regional anesthesia in the ED, initially under supervision of the regionalists who were kind enough to come downstairs all the way to ED every time there was a case. The indications we focused on were acute pain management of the extremities, anesthesia of the extremity for procedures, alternative to procedural sedation, alternative to narcotics in certain patient population, especially those with head injuries or patients with concomitant mental status change. Ultrasound guided regional anesthesia was used as an alternative analgesia in upper limb fractures, lower limb fractures, and rib fractures, and in procedures such as chest tube insertion, CVC insertion, and closed manual reduction or CMR. So, the common blocks that we performed were usually upper limb blocks such as supraclavicular, infraclavicular, axillary, interscalene, and mid-forearm blocks, and lower limb blocks such as femoral, popliteal, fascia iliaca, and truncal blocks such as ESP and PECs. So, what are the benefits, you may ask? Well, analgesia can be targeted specifically to the region of pain, and it can provide relief for many hours. It's an alternative to procedural sedation. It decreases ED length of stay, shortens post-procedure observation periods with reduced need for ED nursing care, and it has proven to have high patient satisfaction. So, this is a procedure overview of a typical case. We usually perform RA in the trauma bay located in the yellow zone or in our RA suite, which we will look at a little later. So ideally, it starts with patient selection. So this is crucial to choose a patient that is right for you to perform RA. We get consent, we do the necessary preparation, and then finally execute the procedure. Post-procedure, you have to evaluate the success of your block and look out for any complications. So monitoring is required. And then we have our documentation, both in the patient's case note and our own database. And finally, upon discharge or admission, we follow up each and every of our patients. This is our UGRA form that each patient receives upon receiving a block. It's modified from the anesthesiology RA forms. To date, we have performed roughly about 120 cases. This is our RA suite. You can find this room in the yellow zone in EDHKL. So this is where we store all our equipments, including our ultrasounds and database. Later in this course, you'll get a sneak peek of this space. This is our block box. This is the block box that's used to perform ultrasound guided regional anesthesia on patient bedside. So we have all the necessary equipments in here that includes needles, syringe, LA agents, atlases, drug dilution tables, toxicity and nerve injury pathways, and references. Right. Now let's talk about post-procedure follow-up. We monitor all our patients for results and immediate complications. So anesthesia should typically be achieved by about 15 minutes. So we monitor these patients for at least 30 minutes to 1 hour following the block. Also, don't forget to inform other healthcare providers that a nerve block was performed and patient will have no function of that blocked extremity for up to 8 hours. For patients discharged, instruction is given on expected block recovery and complications for them to look out for. We follow up all our patients, those admitted, we see them in the wards the next day, and those discharged, we do a teleconsultation in the next 24 hours. Or we review them in our review clinic if assessment is deemed necessary. We also have pathways for each specific complications that my colleague will explain in detail a little later on. This is a follow-up form, and during the review, each of these patients will receive this form whereby we will fill up the patient's details, indicate the types of block they have received, the success rate and the assessment of the block, and we will focus on any possible complications that the patient might have encountered. We further strengthen our understanding during the RA workshops. We have biannual workshops, and all of this is done in collaboration with the anesthesiology department. So our format is simple. We have lectures and we have hands-on skill station. So we focus on training primarily the core team initially. So once all the core team members were trained, we started training all emergency physicians in EDHKL. An expansion of trained personnel in the emergency department with each courses that followed. So the topics of focus varies with a different level of difficulties. So we had our simple, less complex upper limb and lower limb blocks. And we also had truncal and central and neuroaxial blocks. We had stations including the upper limb, lower limb, truncal, central neuroaxial, and vascular. These are the courses that was conducted in 2020. So you can see in comparison from early 2020 to late 2020, the number of participants have increased many folds. This is quite a clear indicative, the interest that is there and the willingness of doctors alike, emergency physicians, medical officers, to learn this new skill and master this new art that they can use in their daily practice. The next, we will talk about credentialing and privileging. So for all our core team members, yes. Next, we'll talk about credentialing and privileging. So for all our core team members, we have an online logbook in commission. How do we do this credentialing and privileging? Well, we divide it into different levels of difficulties. So we have level 1, 2, 3. And in each level, we have specific blocks that are assigned. So for each block, each member is supposed to observe 5 blocks, perform 5 blocks under supervision, and perform another 5 solo with no complication. So once that individual has completed the blocks and is able to actually perform the blocks solo and is credentialed and is confident, only then we would deem them privileged to perform that particular block. This is the example of our online database whereby each member has a spreadsheet that they can fill the patient's detail in. So we have upper limb blocks, truncal blocks, and lower blocks. And all of these blocks is divided according to what we find complex and what are more simpler blocks. So there's different levels of difficulties. Okay, going down memory lane. Well, these are different collaborations that has happened throughout the year between emergency department and anesthesiology. So this was initially done in 2017, and we had one in 2019. And in 2020, when we almost just officially launched, we had 2 separate courses, one in February 2020 and another in late 2020, which was in about November. And we had a practical session in December of 2020. As you can see, we work well and we have very good multidisciplinary collaborations. And the anesthesiology colleagues have been kind enough to share a lot of this knowledge with us and help us train and build our confidence in performing these procedures in the emergency department. So this is a picture of one of our training sessions in the OT. As you can see, this was done in the Regional Anesthesiology bay in the operating theatre. This is another picture of our training sessions. So this is a skill station on identification and cannulation of the needle. So I've come to my last slide. Our take-home message. Well, first and foremost, do it at your own pace, according to the resource that you have at your facility and the manpower that's available to you. You can always start small and expand as you grow. Secondly, multidisciplinary collaboration. I can't stress enough how important this is. We have learned so much from our regionalist colleagues, and having a good relationship among these disciplines is really beneficial for all parties involved, and again, especially to the patients. Prepare and be mindful on the framework of your service. Envision your patient's journey, receiving RA, right from the selection all the way up to their follow-up. And finally, last but not least, this is a new skill set. So training is very, very important. Every day we learn something new and we learn it together. That's what makes it fun. And it is a novel skill set. So to most of us, this is new. So we have to keep at it and practice and practice and practice to perfect our craft. So thank you very much for your attention. Remember, teamwork makes the dream work, and enjoy the rest of the course. Thank you.